Welcome to Safe MRI Practices 2019. This module is designed to meet the annual MRI safety requirements required by the Joint Commission. After completing this module, you will be able to list screening criteria for ferromagnetic materials, medical implants, medical equipment, and patients at risk for nephrogenic systemic fibrosis, or NSF. Demonstrate proper positioning for patients to avoid thermal burns. Explain emergency procedures for patients and equipment. Describe how to protect patients from acoustic damage. Explain how to manage claustrophobic and anxious patients in the MRI environment. In mid-1977, the first human was scanned using magnetic resonance or MR imaging. By the early 1980s, MR scanners were being installed across the country. Today, MRI has become a common household term, much like radiography. Although more people are now familiar with MR imaging, they might not be aware of the safety precautions that must be followed when entering an MR facility. For example, people might not know that the superconducting magnets and permanent magnets used in open MR scanners cannot be powered off. Even if the electrical supply to the equipment is shut down, the magnetic field still is in force. Let's review the main safety considerations of MR imaging. These factors include the force and torque of the magnetic field on ferromagnetic materials, the potential for injury if a metallic object is pulled into the magnet and strikes a person, possible biological effects from the magnetic fields and the radio frequency pulses, and the potential injuries in the event of a superconducting magnet quench. The invisible magnetic force that extends outside the magnet is referred to as the fringe field. It's important for MR technologists to understand the strength of the fringe field and how far it reaches outside the MR equipment or scanner room. The magnetic fringe field is a 360-degree perimeter around the scanner. Floors above and below the MR scanner room must be taken into account when considering safety issues associated with the fringe field. Two factors affect the fringe field: the main magnet's field strength and the amount of shielding inside the MR scanner. Translational force is the primary safety concern involving the static magnetic field. Ferromagnetic objects accidentally brought into the MR scanner room can be pulled into the scanner bore. Objects attracted to the magnetic field accelerate to a high speed and become projectiles that potentially can seriously injure people or damage equipment. A well-known incident involving an MR scanner occurred in July 2001 at Westchester Medical Center in Valhalla, New York. An oxygen tank flew through the MR scanner room, striking and killing a 6-year-old boy. In MR imaging, certain implanted medical devices are subject to torque from the magnetic field, such as ferromagnetic aneurysm clips or non-compatible cardiac pacemakers. In this context, torque is a twisting force experienced by ferromagnetic objects in the body, like shrapnel or implanted medical devices. The magnet subjects these objects to translational and rotational forces, which can lead to serious complications. If MR personnel discover that a patient has an implanted device after the patient is taken into the MR scanner room, the technologist should back the patient out of the room without turning to minimize the risk of torque. If the patient suddenly turns around and walks out of the room, the turning or spinning motion could cause the implanted device to torque. There is no guarantee that walking the patient out of the scanner room in this manner will prevent the device from being subject to rotational torque, but doing so can minimize the magnetic field's ability to twist the device. If a patient with a non-compatible device is accidentally taken into the scanner room, MR personnel should follow the facility's policies and procedures for evaluating the patient and notifying the appropriate healthcare providers. The best method of protection is for the MR technologist to screen patients and others who enter the MR suite, but technologists also can test equipment and objects taken into the MR scanning room using a ferromagnetic detection system or a handheld magnet with a strength of at least 1,000 Gauss. Objects that test positively as ferromagnetic should not be brought into the MR environment. Testing should be used in addition to, not instead of, screening forms and verbal screening. The American College of Radiology has established 4 safety zones within MRI facilities. These zones are determined by the increasing safety risk posed by the magnetic field of the MR scanner. As people and objects get closer to the MR magnet, the risk it poses becomes more severe. Zone 1 is any area that is safe for the general public to occupy without supervision from MR technologists or other healthcare providers. The magnetic fringe fields in Zone 1 are lower than 5 Gauss or 0.5 millitesla, too weak to pose a threat. The 5 Gauss line is the invisible, intangible border within the MR suite where electromagnetic devices like pacemakers start to be affected by the magnetic field. The 5 Gauss line is often marked on walls and floors because it can stray into areas outside of the MR suite if the magnetic field is large enough. Zone 2 is still safe for the general public, but is usually the area where MR patient safety screening occurs and therefore where patients enter the supervision of a technologist. Zone 3. The magnetic fields are strong enough to pose a threat to individuals who are not properly screened by an MR technologist. Hospital or clinic personnel who do not work in the MR department are included in the screening process for Zone 3, along with all patients. Zone 4 is the area of the strongest magnetic field and therefore is the most dangerous zone. Ferromagnetic objects entering Zone 4 can be affected by torque or even become projectiles and are therefore not permitted within Zone 4. This illustration will help you visualize the radiation exposure for different radiographic procedures. Because RF waves are non-ionizing radiation, MR imaging is considered safer than radiography and computed tomography or CT, which uses radiation at the higher end of the spectrum. Although RF waves fall at the low end of the electromagnetic spectrum, they still deposit energy into the patient, which can increase tissue temperature. The tissue warming effect is a biological safety concern in MR imaging. The amount of RF energy deposited in the patient depends on several factors, such as the patient's body weight, the imaging pulse sequence, the repetition time, the number of slices, the amount of patient tissue scanned, and the type of MR imaging coil. The more RF pulses used, the more energy is deposited into the patient, which can cause tissue temperature to rise. The patient might begin to perspire as the body attempts to reduce its temperature. Fans inside the MR scanner help keep the patient cool, and some MR scanners contain an internal temperature gauge that alerts the MR technologist when temperatures inside the bore are too high. If the temperature exceeds the threshold limit determined by the patient's weight and specific absorption rate level, the equipment stops scanning until the bore temperature drops to a safe operating level. The RF coil produces an oscillating electromagnetic field. RF pulses are transmitted into the patient and excite tissues to produce a signal that can be converted into an image. The RF field can potentially cause tissue heating when metallic implants, devices, and other metallic objects inside or outside of the patient's body overheat when exposed to the RF field. Sudden increases in body temperature can cause serious complications for patients with poor thermal regulation due to certain cardiac conditions, high blood pressure, diabetes, or any other condition that affects the ability to perspire. Tissue warming from the RF field can lead to thermal skin burns if the patient's skin comes into contact with a coil, sides of the bore, or a cord. Manufacturer-approved MR padding can help prevent the patient's body from touching the inside wall of the MR bore, especially at high contact points such as the arms and hands. In some instances, a technologist can use non-conducting pads to help position a patient. The MR technologist should remind patients to keep their arms by their sides and not cross their arms or feet. The nerves conduct electrical charges throughout the body, so it's important that a patient doesn't create a closed-loop connection by allowing the arms and legs to cross. When using any type of imaging coil, or electrocardiograph or ECG lead, the wires should not touch the patient's anatomy while scanning because of the potential for thermal burns. In addition, the MR technologist should make sure that none of the wires are looped. Looped wires can create an arc that also could burn the patient. MR-approved ECG leads are made of silver and silver chloride to prevent thermal burns. MR staff should check the expiration date of the leads to ensure they are up to date. All approved MR imaging coils used inside the scanner bore must be plugged into the appropriate slot. Technologists never should send an unplugged coil into the bore because it could cause thermal burns. Implanted medical devices can cause permanent injury or serious complications if the patient is exposed to the static, RF, or gradient magnetic field. Knowing the device name and model number can help staff determine if the device is safe for the facility's magnet strength. Certain implanted devices can cause excessive heating during MR scanning. These devices include cardiac pacemakers and implantable cardiac defibrillators, or ICDs, neurostimulation systems, halo vests and cervical fixation devices, transdermal medication patches, damaged ECG leads, and pulse oximeters. MR technologists also must screen patients for jewelry, body piercings, tattoos and permanent makeup, and regular eye makeup if imaging the orbital area. Any of these objects or conditions could potentially cause burns. RF waves can heat any metallic object, even non-ferrous materials, so it's important to explain to patients with body piercings that all jewelry should be removed. Body piercing jewelry often is made of stainless steel, which is not attracted to the magnetic field but can potentially heat up. Even 14-karat gold jewelry can overheat and cause burns. Permanent makeup and tattoo ink can contain metallic flakes. During scanning, the metallic silvers heat up, causing a burning sensation and skin irritation. Patients with tattoos or permanent makeup should be warned of potential skin irritation and instructed to alert the technologist immediately if they feel anything unusual in the area of the tattoo. Patients having orbital scans should remove all eye makeup because some cosmetics contain metallic flakes. These flakes can cause a void artifact in the orbital area, leading to a misdiagnosis. Technologists should instruct patients to notify MR personnel right away if they experience warming or burning sensations on their body or the feeling of something pulling in or on their body. Gradients are used to change the static magnetic field of the MR scanner to produce the parameters required for various MR examinations. The MR scanner has 3 pairs of gradient coils. Each time a pulse sequence is started, the 3 pairs of gradient coils are activated. The rapidly changing gradient field can produce acoustic noise and peripheral nerve stimulation, which are safety concerns specific to gradients. The loud noises and vibrations created when the gradient coils are turned on and off can potentially damage a patient's hearing. The sequence and duration of the sounds depend on the specific pulse sequence. The FDA has established specific guidelines on the acceptable noise level for MR scanning. MR technologists should provide patients with hearing protection such as earplugs or headphones. All hearing protection devices must provide at least 29 decibels of attenuation. The loud acoustic noise also can cause a patient to stop an examination before it's complete. For example, acoustic noise can lower a patient's tolerance or frighten an individual, especially children. Some patients might develop headaches because of constant loud knocking noise and vibrations. Patients should be told what to expect during the examination. Earplugs or headphones can lower the noise level, however, the patient still can hear the sound and feel the vibrations. Technologists should encourage patients to use the call device if they experience discomfort. MR facilities should have policies and procedures to handle basic emergencies involving patients and should hold emergency drills on a regular basis. MR technologists should follow these basic steps during a patient emergency situation. 1. Remove the patient from the MR scanning room to a safe area as soon as possible before attempting any life-saving procedures. An MR conditional stretcher should be used to move the patient. 2. Activate the facility's emergency response team. Some emergency response team members who respond to MR emergencies may not be properly MR safety trained or screened for contraindicated medical implants and devices. In addition, team members may be wearing or carrying various ferromagnetic materials, such as scissors, beepers, keys, and stethoscopes that could be pulled into the MR scanner by the static field. A patient or other personnel could be injured by a ferromagnetic projectile pulled into the scanner. MR technologists should take the following steps during equipment or environmental emergencies. 1. Move the patient from the MR scanner room to a safe area as soon as possible. 2. After the patient is removed, close and lock the scanner room door to prevent any untrained personnel from accidentally entering the room. 3. Activate the facility's emergency response code. 4. Participate in the decision regarding whether to quench the magnet if fire department personnel need to enter the scanner room with their emergency equipment. Cryogen gases are used to cool superconducting magnet systems, and the release of these gases can represent a safety concern. A quench is a sudden loss of the magnetic field that involves the release of liquid helium at negative 452 degrees Fahrenheit or liquid nitrogen at negative 320 degrees Fahrenheit. In a superconducting magnet, a quench can occur in two distinct ways: as a controlled or planned procedure, or as an uncontrolled, spontaneous occurrence. In a controlled quench, the MR technologist might have to rapidly reduce the magnetic field in response to an emergency situation. An example is when a metallic object physically pins a person against the magnet, or when a large metal object, such as an oxygen tank, floor buffer, or stretcher, is pulled into the magnet and cannot be detached. If the trapped person or object cannot be removed, the MR technologist may have to start a quench by pushing the emergency quench button. Larger metal objects have greater magnetic force and may be difficult to remove from the magnetic field. If there is no immediate danger, the MR service engineer can be called to slowly release the cryogen gases and gradually dissipate the magnetic field, so the item can be removed. Another example of a controlled quench is when the magnet undergoes maintenance or is decommissioned. A controlled quench by a qualified service engineer is always the preferred method when possible. An uncontrolled or spontaneous quench can occur when system components fail without warning, and the failure causes the temperature of the cryogen gases to rise. A hissing sound caused by the slow release of cryogen gases may be heard just before a full quench occurs. During a quench, the cryogen gases that normally help cool a superconducting magnet are released into the MR scanning room. An exhaust tube should vent the cryogen gases to the outside air. If the vent flap becomes stuck or frozen shut, the cryogen gases can fill the scanning room, injuring anyone exposed to the gases. Doors to the MR suite should be installed to open outward because the room pressure during a quench would prevent a door that swings inward from opening. All facilities with MR equipment should have emergency evacuation plans as part of their policies and procedures. Cold cryogen gases can cause frostbite or asphyxiation. Unvented cryogen gas molecules expand, increasing the pressure inside the room. The sudden increase in pressure can rupture a person's tympanic membrane. Technologists should remain calm and evacuate all patients and personnel from the MR suite according to their facility's policies and procedures for quench emergencies. Patients and personnel should remain outside the room until the air has returned to normal. Technologists should contact the MR service engineer to inspect the room and equipment. Once the service engineer replaces cryogen gases and considers the system ready, technologists can resume MR scanning. This process may take several days or weeks depending on the extent of the damage to the system components. A properly designed room should have an exhaust grill in the ceiling opposite the room's entrance for venting gases. The room also should have a passive backup system that can discharge gases in the event the primary exhaust system malfunctions. These systems should be checked annually by the service engineer. Technologists should be careful when opening an outward swinging door because the increased room pressure can cause the door to open forcefully and may cause injury. The ACR cautions against breaking control room glass to vent and depressurize the scanning room in a quench emergency. Shielded control window glass may be too thick to break easily and quickly enough in an emergency. MR personnel have an ethical and legal responsibility to ensure that anyone who enters the MR department undergoes a thorough safety screening. Ideally, the MR patient is screened 3 times before entering the MR scanner. In addition to patient safety considerations, the high cost of MR examinations is yet another reason to identify patient contraindications before scheduling to minimize patient no-shows and unfinished examinations. The referring physician should pre-screen the patient before ordering the MR examination. The physician should check for factors that might contraindicate the examination, such as non-compatible cardiac pacemakers, pacemaker wires, or ferromagnetic aneurysm clips. Pre-screening also should include verifying that the patient's size and weight do not exceed MR table specifications. Referring physicians should ask whether a woman is pregnant when determining if she is a candidate for MR scanning. Pregnant patients who undergo MR examinations might have to sign a special consent form. If a patient is claustrophobic or has excessive pain, the referring physician should prescribe an anti-anxiety or pain medication to make it easier for the patient to complete the MR examination or remain still during the exam. Certain exam protocols may require the use of an intravenous MR contrast agent. A patient may require laboratory tests to check blood urea nitrogen along with creatinine and estimated glomerular filtration rate levels before receiving contrast. If so, MR staff should obtain these laboratory results according to departmental policies and procedures before the patient arrives for the MR examination. Patient care and safety should be the top concern of all MR personnel. By contacting patients before their appointments, the MR facility can let patients know what to expect and how to better prepare for the examination. For example, some exams may require the patient to have nothing by mouth or NPO, and MR personnel can remind patients of any necessary preparations to prevent cancellations. In addition, patients with claustrophobia can be instructed to contact their referring physician for the appropriate anti-anxiety medication. Many MR patients are anxious about their examinations, and long wait times make them more anxious. Minimizing patient wait times and improving safety at the MR facility includes preparing for potential complications before the patient arrives. Pre-screening a patient helps MR technologists and radiologists prepare for the MR examination and ensures the ordered examination and use of contrast are appropriate. Here are examples of questions that should be asked. Inquire whether the patient has had a previous MR examination. If so, ask when and where. Ask whether the patient has ever had a reaction to a contrast agent or to iodinated contrast media. Ask about prior medical imaging. Inquire whether the patient has a history of allergies or asthma. Inquire whether the patient has a history of significant cardiac disease. Ask the patient about any history of renal disease, including renal disease in first-degree relatives. In addition to the pre-screening questions, the technologist should explain the procedure and be prepared to answer any questions the patient may have about the technical aspects of the examination. Most patients tolerate gadolinium chelates well. The U.S. Food and Drug Administration provides guidance concerning the development of nephrogenic systemic fibrosis, or NSF, in patients with moderate to end-stage renal disease following exposure to gadolinium-based contrast agents, or GBCA. Much is still unknown about the disease and the role gadolinium plays in causing it. The patient should receive a medication guide the first time a patient is scheduled for an MRI exam that requires a GBCA injection, or any time the information regarding GBCA injections changes, that explains the potential effects of gadolinium-based contrast agents. The risk factor since has expanded to include patients with stage 3 through 5 chronic kidney disease and acute kidney injury. New recommendations suggest patient assessment should begin with a medical history, but providers should not rely solely on this information. The patient's glomerular filtration rate also should be tested no more than 6 weeks prior to administering contrast. Technologists should follow their facility's guidelines regarding laboratory testing and contrast media administration. Specific agents do not pose equal risk of NSF. Contrast media most associated with NSF include gadodiamide, gadopentate dimeglumine, and gadovercetamide. Dosage also seems to affect risk. If the pre-examination assessment shows that the patient is at high risk for NSF or other contrast reaction, the referring physician and radiologist can consider alternate imaging examinations that do not require a gadolinium-based agent. The following checklist reviews steps MR personnel can take to reduce safety incidents. Ensure the patient has the correct order from the referring physician. Pre-screen patients for contraindications, such as non-compatible pacemakers or ferromagnetic aneurysm clips. Pre-screen patients for surgically implanted devices and details such as device name and model number to verify that the apparatus is safe for the facility's magnet field strength. Ensure that pre-screening radiographs are completed, reviewed, and approved by a radiologist. If contrast is indicated, ensure the appropriate lab work is completed, reviewed, and approved. Ask whether a female patient of childbearing age is pregnant or breastfeeding. Verify that the patient's weight does not exceed the MR scanner's table weight limits. Remind patients with claustrophobia to discuss pre-examination medication with their referring physician and that they may need a ride home. Inquire whether patients who will receive a contrast injection have any known difficulties with venipuncture. If so, instruct the patient to arrive early to allow a qualified healthcare provider additional time to start an IV. MR technologists who are trained in MR safety do the final patient screening. MR personnel review an MR safety questionnaire with the patient or the patient's legal guardian. If the patient is unable to respond because of dementia or other condition, a person who is qualified to answer questions about the patient's medical history, such as a physician, family member, or legal guardian, should complete the safety interview. If the patient or the patient's representative is hearing or vision impaired, not fluent in English, or has problems with literacy, MR personnel should follow their facility's policies and procedures regarding interpreter services. If a patient is unconscious and no family member or representative is available who knows the patient's medical history, physicians must determine if the MR examination is absolutely indicated. The patient must be examined carefully for scars or any sign of previous surgeries or metal on or in the body, and radiography or CT imaging should be performed and approved before continuing with the MR examination. Physicians requesting the examination must sign special informed consent, and all personnel involved should follow the facility's policies and procedures. Education is a key component to ensuring the cooperation of the patient. The patient needs to know that remaining still during the examination helps produce motion-free images and minimizes the time he or she is in the scanner by decreasing the need to repeat a series. The MR technologist should demonstrate the intercom system and squeeze ball, as well as the levels of bore lighting in the bore fan speed. It's also essential to remind the patient about the loud noises that occur during the examination. Informing the patient about the expected exam length may help the patient better tolerate any discomfort. Extra care should be taken with special needs patients to ensure patient comfort and avoid movement during scanning. For example, some patients might require additional padding. Others might have drains, IVs, Foley catheters, and other medical devices. MR technologists should remain aware of a patient's breathing tube and any other lines when placing coils, so that the tube or line is not disturbed or disconnected. Technologists encounter situations that are not textbook perfect, such as claustrophobic patients, and at times, conventional coils might not fit some patients. For example, the head of a patient with acromegaly and facial bone enlargement might not fit into the usual head coil for a pituitary scan. Some patients are confined to wheelchairs, are on stretchers, or have a body habitus or condition that presents positioning challenges. For example, MR technologists may need to be creative for the lateral decubitus positioned patient and perhaps use a flexible coil or other coil for the patient's brain scan. Special patient monitoring may be needed for unconscious patients, those who are hard of hearing or have weak voices, pediatric patients, special needs patients, or those under sedation. Typical monitoring equipment includes a pulse oximeter, blood pressure cuff, and electrocardiogram or ECG equipment. When monitoring a patient's ECG findings, it's important to understand the magnetic hemodynamic effect on ECG waveforms in a magnetic field. The ECG waveform may not be sufficient for accurate patient monitoring when running certain sequences. Some patients are extremely anxious and cannot complete a scan even after sedation is attempted. These patients may require anesthesia. Although larger facilities might have MR safe equipment, some anesthesia equipment is not MR safe and thus cannot be taken into the MR room. Anesthesia personnel who plan to be in the MR room must be screened for safety before entering. This concludes Safe MRI Practices. You should now be able to list screening criteria for ferromagnetic materials, medical implants, medical equipment, and patients at risk for nephrogenic systemic fibrosis, or NSF. Demonstrate proper positioning for patients to avoid thermal burns. Explain emergency procedures for patients and equipment. Describe how to protect patients from acoustic damage. Explain how to manage claustrophobic and anxious patients in the MRI environment. This module was created in the style of ASRT Online Continuing Education. If you would like to complete similar modules for